do flea markets have in common with research? Fasten your seatbelts and travel with us into the future of cartilage, together with Professor Mats Brittberg from the University of Gothenburg and Dr. Jari Dahmen from Amsterdam University Medical Centers, University of Amsterdam. My name is Takao Shima and this is On The Go, the podcast all around orthoregeneration.
All right. Good evening, Mats from Amsterdam. It's currently 6:30 in the evening here, and we usually start with the question, how do you drink your coffee? But let me welcome you to the show, and welcome.
Thank you very much, Jari. And my coffee is black, and I drink coffee in the morning at 10 o'clock, at 12 o'clock, at 3 o'clock, and at 7:30. So that's a lot of coffee.
And after 7:30, no coffee anymore.
No, well, I could take it even a little later if I want, but only 1 cup. If I drink 2 cups, then I will have less difficult problems for the night. Then I will be awake all night.
And what time do you usually wake up in the morning when you go to work?
Well, I go up at 5:50 in the morning. Nowadays, I could walk to the hospital, so I have a brisk 10 minutes walk to the hospital. So it's good. So we start at 7:30 in the morning in the hospital.
All right. And then the second question for you is, what is your favorite place to just calm down and have a coffee? Where is that?
Well, as you heard, I'm drinking at different times. So there are different spots in the morning. I drink coffee at the breakfast, and then I drink coffee with my colleagues. And at lunch time after lunch, a couple of cups, and in the afternoon with the staff. And when I come home, I drink with my wife. So you have different favorite spots during the day.
So not only one, multiple favorite spots during the day. That's clear. Perfect. Okay. Well, then we're off to the questions of our theme, and our theme of today is the future of cartilage, 2040 vision. So Mats, just imagine that it's 2040 on this day that we're speaking. And how do you see the future of cartilage in front of you? How would that look like?
Yeah, it's certainly quite a difficult question, because if you look back like 20 years, not so much has happened since we started with the chondrocytes and cell transplantation. There are different ways of how you interpret MRI, the way that you choose new scaffolds and so and so. So 20 years ahead, we'll be more able to define the cartilage lesion by our radiology, I believe. We will be able maybe to order our implant, and I think it could be allogenic cells. Allogenic chondrocytes will certainly be a possibility that we could order, and we could order them, and then we could bioprint them transarthroscopic to treat the local defects. But we'll be also able to treat larger defects with new technology, and with the way that you have artificial intelligence, I think we will be using that as part of our way to analyze and to choose the right treatment for the right patient. But it's certainly very difficult, because what you think will happen in 20 years most often happens very slowly, not the way that you would expect.
So we think that we are ahead in 40 to 50 years, but the times for the 20 years just go by slowly. Also for research. And the first part that you were mentioning on the radiological part, when I asked you about the 2040 vision, you mentioned that we will be able to localize the lesion better and to interpret it better. Could you just go into a bit more detail on this radiological part for 2040?
Well, today when you have a patient with pain, you do normal X-rays to see the alignment and the joint space narrowing if it exists. Then you do an MRI to look upon the cartilage and the rest of the joint. And then you could see that there are cartilage lesions, but it's still difficult to know exactly the size of the lesion, because when you do an arthroscopy, you will realize that most often those lesions are larger because you do the debridement. But with new technologies, you could see the quality of the surrounding cartilage, and you could also, after a surgery, you could evaluate better the repair tissue quality. Today, it's still quite primitive, I would say. So I think we will have an enormous development in that type of technology. And it's like yesterday, I saw an advertisement for a new objective, a new lens for my camera, and it was a lens for macroscopic photography, to go into small sizes and to look upon small animals when you took photos. And I think we will be able to analyze the small details better. And when we analyze them, we could also understand how the repair is really functioning in the defect area, and to stimulate the repair better. So I think we will get further down into the micro world to analyze the repair, and by that we will better in our repair attempts.
All right. So if I understand correctly, through the developments in radiology and through developments in arthroscopy, we'll be able to better treat our patients and to also predict the outcomes in a better way.
Yes, and also you could believe that because you see the quality of the cartilage, you could say this patient has an early OA that needs another type of treatment than the patients that have a pure traumatic lesion with nice normal surrounding cartilage. Because today it's still difficult to know exactly the surrounding cartilage quality, and that could also influence the repair. And if we know better, then we could induce chondrocytes or stem cells that could produce new stimulation for the cartilage surroundings. So we manipulate the cells to produce the right type of growth factors.
Mm-hmm. So I think that those statements are in line with your previous thought that also artificial intelligence will play a big role in 2040. You mentioned a bit about responders versus non-responders, for example, with the OA people and the non-OA patients. What do you think the role of AI will be in 2040? How will it help us?
Well, AI is interesting because certainly it's not better than the way what you put in is what you get out. So certainly the speed that artificial intelligence could scan the research to find things that normally you need a lot of fantasy to and a lot of work to go through papers, it will be speeding up our possibility to analyze ideas that we get. And it's also our fantasy that will ask the right questions for artificial intelligence, and it will help us to analyze the patient and give you like a verdict that this patient could be a good candidate for that type of treatment, or that patient need also an osteotomy. But at the other hand, it's also important that the persons that are to handle artificial intelligence, they must be also very well educated, because it is like today when you ask questions on internet, it's also the way that you analyze the answers you get, because there's a lot of misinformation out there, and that's important so we don't get into the wrong path in order to get the patients to the right position.
Mm-hmm. And are you using any artificial intelligence currently in your clinical setting?
No, but it's interesting because besides doing cartilage repair, I'm in the hospital I'm working today is a lot of acute treatment, a lot of fracture treatment. So I think the way that you decide how to treat difficult fractures could be helped by AI, but also in the future to choose the right type of cells and to analyze the patient's concomitant diseases, what could influence. For example, a lot of medicines could have negative influence on the repair, like statins that could have negative influences on muscles and tendons. And if you know different types of medicine could have negative influence, then if you have an aged patient, you could realize that this patient is not so good for that type of treatment. Then you have to change the patient's normal medical treatment and to choose something else during your local repair technology. So there's a lot of things you could do, but still you have to sit down and together with your colleagues to summarize what is the best solution. And then you could ask the question, and by AI get support for your thoughts. So still I think, at least in the future, near future, AI will be a support to us. It will not give all answers. We have to analyze it and we have to understand the answers.
I fully agree on that one, and I think that revolution will definitely take place. Just diving a bit deeper into the AI and the revolutions that are necessary in the upcoming 20 years to bring us further in cartilage treatment. How would you answer the question that if I would ask you, if you have an unlimited amount of resources and unlimited amount of financial input, what kind of research would you perform with your team to get further in the upcoming 18, 17 years?
Yes, you mean in orthopedics, in cartilage repair?
Yeah.
Or in generally in all?
No, in specifically for cartilage repair.
Well, we should certainly put. Yeah. Well, I think we should certainly put a lot of effort to follow the patients, young patients, for a long follow-up to see how to know more about the development of cartilage and to learn how the cartilage is produced in the fetal stage in order to be better to reproduce what nature once gave us. That's one thing. And then also to know more about aging and osteoarthritic development, because, still people, when we talk about cartilage, have difficulty to differ between local cartilage repair and fully developed osteoarthritis, even though local defects could develop into osteoarthritis, what we call the post-traumatic OA. Still a lot of patients have OA by increasing age. So I think more about aging of cells, because today when we do transplant of chondrocytes, we do transplant for young patients and up to about the age of 60. The efficacy of those cells when we are aging are less good than in the young patients. So we should learn more about how to use allogenic cell sources, because then we will be less dependent on cell culture. We could already have prepared cell batches for patients when we have allogenic cell sources. And if we learn more about how to use these cells in order to know that they are safe to use, they will not transmit diseases and so, I think allogenic cell sources will be something that we should put a lot of extra money on. And also another thing that we not discuss so much today is actually preventive treatment to prevent patients not to develop cartilage injuries. That is maybe one of the most important parts, both in sports but also in aging people. So I think I would put a lot of money on allogenic cell sources and then also on preventive medicine to prevent joint injuries and by that less cartilage injuries as well.
Mm-hmm. So that brings us also to to the cascade of cartilage damage from a trauma to either genetic predisposition to very focal cartilage lesions to osteochondral lesions and then to OA. And mentioning the preventive treatment options, I think currently you are definitely mentioning the first part, so preventing the trauma, for example, or preventing the injury to happen. Going in a bit deeper into, for example, when a trauma has happened already, what kind of secondary or tertiary preventive treatment options that are also treatment in that sense are you currently researching, and how do you think that preventive treatment will be in 20 years?
Well, preventive treatment is, for example, to have less knee injuries, ACL injuries, because ACL injuries will produce also meniscal injuries and by that also cartilage injuries. There are a lot of focus on play training to be well prepared, but also I think we should look upon different types of braces that could be used during sport that could prevent injuries. And it's also for the elderly patients that will easily have problems with fall trauma by instability when their muscles become less active and you have less balance. You should also know how to train them better because in the long line of injuries, especially in sport for the young ones, in traffic accident for the people and for the elderly people that easily fall in their homes, that often get them off their activity level, which is very negative, especially for the old people. And for the young persons, they could have problems for the rest of their life. So cartilage is part of it, but most often cartilage injuries are not left alone. There are ligament injuries, instability, malalignment, and things like that due to fractures near the joint and so on. So I think more and more than I see more and more trauma that we should work quite heavily on preventive medicine for this thing.
Mm-hmm. And do you think that in about 20 years, because currently there are many developments for innovative technique options, for example, injection options consisting of a cocktail of different kind of biologics. Do you think in 20 years that there will be a personalized injection option consisting of certain stem cells that are specific to the patient?
Well, it's an interesting question, and it's certainly we could talk a lot about it because, if you talk about different types of injection treatment like PRP, I think PRP could be something if you have like an allogenic source where you know exactly what you inject into the patient. But today, most people get autologous their own PRP, and you have a variation of the concentration of growth factors in the PRP injection from hour to hour, from day to day, and from patient to patient. So to do studies with autologous PRP is very difficult, but I think if you have developed an allogenic PRP or allogenic growth factor injection, so you know exactly like a pharmaceutical drug, this is what everybody gets, then you can more decide how to treat the patient and which concentration you should use. And I think it's the same when you are going to use stem cells. Stem cells are more or less used as growth factor producers into the joint. So that is interesting, but then you should also look for allogenic sources, because if you take stem cells from the fat tissue, for example, from an elderly patient and compare it with a young patient, you will have differences. So if you have an allogenic source from young patients with those stem cells, I think that could be something for the future. But also what is interesting is that you could look about what the cells produce, like what we talk about exosomes or secretome. That is quite interesting, because certainly the cells respond on other cells' reactions, and by that you have some sort of production of growth factors. But we need to control it. We need to know exactly what we inject into the patient, because if you just take fat tissue from me and compare it with fat tissue from you, we will have different responses. But we should give the patients that idea that what you inject is the same that you and I get, so we have the same chance to get an improvement from the injections. So that's a challenge for the future, but we have to look upon allogenic sources more, I think.
All right. I think enough to do for the upcoming 20 years if I listen carefully to what you say. We have many years in front of us, so that's good for our researchers and the clinicians. We have some time left, so we'll first go on to our in-betweener questions, and then we'll go back to the 2040 vision. So first question on that one: what is your guilty pleasure? What's Mats' guilty pleasure?
Well,
it can be anything.
I like good food and good wine, and I like to be out in the nature. I like to go out in the nature to take photography, especially birds and beautiful things, flowers and so on. And I have interesting during the weekends to go to flea markets.
What do you buy on the flea markets?
On flea markets, I look for beautiful things, special things that you normally don't find in the shops. It could be nice paintings. You could find nice books, nice glasses for wine that is hand blown or things like that. So it's also the thrill what you are going to find, and it's like research. You never know what you are going to find, but you could find beautiful thing in research, and you could find beautiful things in the flea market, and then you meet a lot of different persons with different ideas and work, and we have a lot of nice discussion. We try to solve the nasty parts in the words by discussion in Saturday mornings when we are waiting in the queue to go to the flea market.
What is the best thing that you've found on a flea market?
The best thing, well, it's difficult. I actually found a lithographic printing made by Chagall, the famous painter, and I found a nice ceramic pot. It's for lime leaves. It's from Cambodia, from Kampuchea. It's from the 1100s years, so it's a very old one. So that was also a nice finding. But that's not so normal findings, but sometimes you find nice things and very unusual things. So it's a little thrilling.
It's a very rare and special finding maybe you could also compare it to your finding of the ACI that you published in the New England. I don't know if you could compare it like that.
Yeah, certainly. When you do research and you find something unusual, sometimes you find something that you were not expected to find, and you become a little disappointed. And then you realize if you think the opposite way, it's actually also a nice finding that people would make use of. So it's often that you look for positive findings. You expect to find this thing, and when you don't find it, you become very disappointed. But then you should sit down and take your time and say, this negative finding may be the solution that we have looked upon, but we didn't understand it that way. So you always have to look on different angles on your research to find the nice answers. And then these new findings will be a new brick to build up your knowledge. So it's time-consuming research, and sometimes you become very disappointed because you made your research for several years and you came out with a negative finding. But that negative finding will help many other researchers to build together a strong wall for to climb to the next step in the research.
Mm-hmm. So just with the analogy of the of going to the flea markets on a Saturday morning, you will keep doing that, and you will keep doing the research to try to find something new. And what are you currently aiming at for the coming 10 years? Where do we see the next special finding of Mats?
Well, it's little of what we touched before, like to see how we could use the cells the best way, how we could know the language of the cells. If we know more what they secrete in the certain situation, then we may know how to control them better, how they mix them with other cell types, and how they commute in the cartilage defect. And how they start to commute in a bad way to produce a war in the joint, the development of an osteoarthritis. I think the way that we could listen and we learn the language of the cells better, I think that is one part of the future. But also, we treat the cartilage lesion not because they are there, because we treat the lesion because the patients have symptoms, and mainly because they have pain. And pain is the main reason why we are working with the patients. And certainly we know too little still about how to manage pain, especially when the patient goes from an acute pain that we are quite good to handle into chronic pain patient situation. And there are so many patients with joint pain that were not suitable for cartilage repair. They are not suitable for prosthesis surgery. They are somewhere in between, but still they are in pain situation. And we have the patients that develop these complex regional pain syndromes from minor trauma. So I think that's also part of it. And to work on joint pain, we learn also how to control the cells, because the cells need some information, and the information goes via the nerves. And there's one interesting paper where they showed a patient that had a paralysis in her right arm, and she has a healthy left arm. And in the left arm, the patient has developed osteoarthritis of the wrist, but in the paralytic arm, there is no osteoarthritis. So the messenger didn't have the possibility to send the message via the paralytic arm, and there was no development of OA in that part. So certainly that's interesting finding, that we should also know more about the messenger. And sometimes people say that osteoarthritis, at least the primary or non-traumatic osteoarthritis, could be a neurological disease by that way. So the nerves are the the lines for information, and we should learn more about that also when we are doing cartilage repair.
Mm-hmm. So we should work more together with neurologists to find out what this etiology might be.
Yes, neurologist or maybe physiologist that knows what's happening in the connection between the nerves and how they communicate, and the different inflammatory cells. We should also work with immunologists because immunology is very important part of disease development, and how also, the cells that are part of immunology are also part of the pain system. So they are in between there and back again. If we know more about how they speak, the language, the communication between the different types of cells, to start a repair or to go into a destructive signaling system, the way that you go in between these types of effect on the joint. And in early trauma, there's a lot of evidence that you could see, both inflammatory evidence, important part of the repair, but also inflammatory effects that are negative, that could be destructive.
So 2040 will then be a multidisciplinary research team and clinical team trying to find out the etiology of cartilage, if I understand.
Yes,
your
I
answer.
think it's important that you know that you have different specialities. You have, like ICRS, the societies that started, that should be a collaboration between basic scientists and clinical researchers. And in the beginning, it was more like a discussion club. And I think this is what you should do in research. You should try to meet with different specialities and have brainstorming about the different situation, because sometimes you will learn more. And when we had a research, I had a research fellow, Birgitta Gautenholm. She was to look upon neuropeptides in the subchondral bone. And in order to have good collaboration, we found out we could work with people that were doing research on Alzheimer's disease. And it happened like what we looked upon, the neuropeptides, it was useful also for them in their Alzheimer research. So you could see similarities and you could support each other, and together we could then have findings that could be beneficial in different directions. So multidisciplinary research is quite important, I think.
So I think going on to the conclusion of the podcast, because we're slowly getting to the end of it, is that that when you are on a flea market on a Saturday morning, you should look together for the nice pearls of new findings, and through that you will be able to find something that you've never found before.
Exactly.
Well, that's a good way to end the podcast, because we've discussed in a deep manner how 2040 will look like, how the future of cartilage will look like, and I think that has inspired many listeners to go back and see where we go, and to perform some innovative
and if
research.
you go to the next door and to the next in the next corridor where they're doing other types of research, and so maybe we should take a cup of coffee and to have a little brainstorming, and then suddenly you will see that you could work together, and maybe you will have the right type of findings that could help the patient for the future. So collaboration is important.
All right. Thank you very much, Mats Brittberg. It was a pleasure and an honor to speak to you, and hopefully we will meet again in the future to continue our talks.
Absolutely. Thank you very much for having me in this discussion. It was very nice.
Thank you, Mats and Jari, for this inspirational discussion. Let's fasten our seatbelts for an exciting future and advance author generation together. Stay tuned for more content at my.on-foundation.org. Thank you for listening and have a great day.